It is an absolute honor to be here tonight. I want to thank Dr. Parikh, Dr. Herman for having me. It is an honor to be here. It is a pleasure, actually, to be here with so many friends, so many colleagues. I love being here with everybody. I'm very humbled to be here in front of some of my mentors, and I haven't met everybody in the room, and we're gonna make this talk a little, fourth groomsman's gonna talk a little quicker. But as David, I didn't know I was going to be introduced, so I figured I would make a slide like, who the hell is this guy? My name is Jonathan Aliota, obviously. I am an interventional cardiologist. I do a lot of PAD work. I do coronaries when I'm forced to. In full disclosure, my children, I was making the slide deck when I had my boys, and they demanded I put a picture of them in the talk. So this is their slide. When I'm not working, I'm in a GT4 car usually, or prototype, and it's a great way to incinerate cash. Yeah, if you want to learn how to burn some money, you guys call me after this talk, and I'm going to show you how to get that done. The most important thing about me, though, is that I was really, really well trained, and this was our graduation photo 15 years ago from the Texas Heart Institute. And Dr. Strickman, I see you in there. Dr. Crazier, you're in there too, and it's very, and JT's in there right in the front. It's very humble to stand up here tonight in front of everyone, in front of greats in cardiovascular medicine, and I think it is truly a wonderful community we have here in Houston. We've done some remarkable things. I'm literally the only person that's aged in that photo. As you can see in the upper right-hand side, everyone else looks pretty much the same. There's Dr. Carr, there's Dr. Loyoka way at the top, Dr. Diaz over in the corner, Dr. Hogan. Okay, we're gonna go pretty quick here. I'm not going to use my reading glasses, but essentially we're going to do kind of a modified case conference. I thought to myself, what could I possibly talk to this group about? And I thought about trying to impress you all with some kind of PAD case, but then I realized I was following Montero, and I was like, there's absolutely no way he's going to show some case where he recanalizes the axillary artery to like the toe, and it's going to be ridiculous for me to try to follow that. So instead, we're going to do something quick and easy, and maybe show you a piece of technology that you might not have seen yet. So we're going to talk about it clinically with this case. 88-year-old woman, she's got hypertension, diabetes like everyone, CKD. She smokes, and she presented to the clinic with dusky right toes. On her initial diagnostic imaging, she had a very, very low ABI of 0.44, and pretty much always after under 0.5, you're going to see the patient to have a CTO. Great toe pressure was awful, it was under 40, so obviously the toes were at risk. When you looked at the velocities on the Doppler, her SFA in the distal was only 46 centimeters a second, which is super slow, suggesting that's probably filled by collaterals. And then by the time you got to the popliteal artery, it was only 11 centimeters a second. There's basically no flow in the pop. So we took her to the lab. This is our original angio of the aorta, so this is pretty common in our world. When I started right after fellowship, these things were kind of horrifying, but we get these very, very calcified, tortuous aortas, and we're not even really appreciating it in 3D. It's just awful looking. Here's the runoff. I don't know if I like doing the slide with two images, but we'll go faster. It looks like the SFA is pretty okay. And then on the second shot here, you see that there's a pretty tight lesion on the first third of that frame, and then what looks like a very short segment CTO in the second. Here's a close-up of the CTO, where you see an 80% lesion proximally, and then again, a very short segment CTO, very highly calcified. Oop, let me go back to that. That's a still frame of what we're talking about. I use a lot. Everybody's different. And I think what's great about PAD, what I love about PAD, is it really allows you to be creative and inventive. I have a lot of patients that have chronic kidney disease, so we use a lot of 50-50 injections. So while I'm really trying to show you nice angios, I'm not a poor angiographer. I would have my hand slapped if I were, especially in this room, but I use a lot of 50-50, sometimes even diluted more than 50-50, just to try to preserve contrast. I try to do most CTOs for under 30 cc's a day, if I can. This left frame certainly shows the short CTO segment. So, of course, we're going to try to address it. Just to be a good boy, I shot the distal runoff, which is awful, single vessel, and into the foot, even worse. You're seeing very, very small, ratty, chronically diseased vessels. So we put a 45 pinnacle up and over. And then what I did for that second shot is I just put a little Seeker 018 Seeker catheter right at the tip of that CTO. And sometimes to cross the CTO, what I found doing a lot of these cases is that so many CTOs have microchannels that you don't appreciate if you don't really put a catheter right next to them. I used to shoot, we don't have digital runoff at Memorial City, but At Luke's, we would shoot digital runoff. Instead, here, I'll tend to put a glide catheter almost as close as I can to a CTO segment, pump it with nitro if I can, take an angio, see if you see any channel at all, If you have anything, a hydrophilic wire is going to go. In this case, I had nothing, but I still tried to put a catheter up there and see if we could pop through it. We're able to cross it here, or I think this is just another segment of just trying to get through it. I can't really actually see without my reading glasses because I've been out for 15 years and no one mock me for this. But this is what it looks like after we try to get through. And so what I wanted to show you is a new piece of technology, and I called the Javelin catheter. And while I was supposed to be talking about shocking versus spinning, I wouldn't dare try to pick one of those two technologies and try to leave this hotel alive. So instead, I'm going to show you something a little bit new. If you've seen the Javelin catheter, it's essentially a shockwave catheter, but it's pulses only at the tip of the catheter. It's super interesting. It's a forward-facing shockwave IVL device. It is hooked up to an insufflator, but what we're doing there is kind of cooling the catheter and providing a little bit of transmission fluid for the electricity. So we're infusing a little bit of fluid during the IVL pulses, but essentially the pulse is coming from the tip of the catheter. The idea of this catheter was for cases where you couldn't advance balloons. We had some deliverability with IVL catheters in the past, situations where you might want to use forward cutting atherectomy or orbital atherectomy. Certainly pilot hole atherectomy, which we do a lot with the CSI device. Essentially, what this is doing is fracturing the calcium, causing the sort of media part of the vessel to fracture and hopefully have a better angioplasty result. Personally, I think this is a huge component of atherectomy as well, and I think modifying that calcium in the media of the vessel is everything if you're looking to do a balloon-only result and not have to stent patients. Try never to stent any SFA if I can get away with it, because the consequences of a stent 6 to 12 months later are just usually awful to deal with. I promised Dr. Kihani back there that I wouldn't show a single data slide, so I'm going to flip right through this. The only part that is worth noting is this is the original IDE. It was safe. People didn't die. There was a mortality blip of statistic, but that was an unrelated catheter death in a patient that had a STEMI. Of course, you know these patients are high risk for cardiovascular disease. So this is what the catheter looks like, also my bone density, and we are passing the catheter very, very, very slowly, slow forward pressure as we're delivering the IVL pulses moving forward. You can kind of see the catheter skipping through the lesion. I did another one without my arm, show that I knew something about radiation safety. And you can actually pulse it forward and backward. And again, the idea is just to kind of break up the calcium. Currently, for indication, we want to have it over the wire, and you want to have a wire already through the CTO. Questions are, could you do it blunt-ended on a proximal cap of a CTO? And I think that's a great question that I would like to soon answer. This is an angio that I did for y'all just to see what it looks like after one run of this catheter through. You can see a very, very slight channel. And that's, I think, what you can't really appreciate about modifying calcium is that when you don't necessarily, these devices, CSI device, IVL device, you're not looking for an incredible result just with that device, but what you're hoping for, kind of like molding sand, I guess, if you will, that your balloon angioplasty will result in a really nice finish. So this is what we got after the very first. Of course, there's a proximal lesion. We treated that too. I didn't video it. And this was after a 6mm Ranger balloon at four atmospheres for 4 minutes. Well, my detention span would never allow 4 minutes. For 2 minutes, which is 4 minutes in my world. So we got a really, really nice result just with the two technologies, and are hoping with good walking program that this will stay open. Or just being a goofball there, the catheter is called the FLX, so we felt we had to flex. It's not that funny, but I thought I'd put it on there. Anyway, that's it. That's all I got. This was my best ability to do the Wolf of Wall Street finish, so.